I think we're good to go, Jen.
Good to go. Let's make a start.
Yeah.
Great. Can I welcome you firstly to this evening? My name is Jeanette Cameron. I'm the Primary Care Commissioning Project Lead at Northwestern Melbourne Primary Health Network. Great to have you along tonight for our core training for non-clinical staff. Can I begin the session by first acknowledging, offering an acknowledgement of country? I would like to acknowledge the traditional custodians of the land on which our work takes place. For us and for me, that's the Wathaurong Woiwurrung people, the Boonwurrung people and the Wathaurong people. And pay my respects to elders past, present, emerging, as well as paying my respects to any Aboriginal and Torres Strait Islander people on our session with us today. Just a few quick housekeeping notes before we start the session. So everyone at the moment is muted. We have a big group of people with us tonight, so just to keep things going along, everyone is muted. We are really interested in your questions though. Could you please place any questions into the Q&A box, and we will be looking at those as the session goes, and asking some questions along the way, and also looking at some questions at the end of the session as well. This session is being recorded, and so the questions will be asked anonymously just to protect your privacy. Just a quick note on making sure that we've got your right name. So please ensure that you've joined the session using the same name that you registered for the event. This is the name that we use to give you your certificate of attendance. So it's very important that we can align that up to get that through to you accordingly. And if you're not sure of anything, please feel free to use our chat icon. We have a number of support people online that are also supporting this process. And I'd like to introduce now Rivka to you, who is our speaker this evening. And Rivka comes from the Medical Business Services. She's a Director of Medical Business Services and Medical Business Coaching that provides a wide range of activities, including consulting, advisory, coaching, training and mentoring services. She's got a particular passion around primary care business management, and many of you may have seen her presenting in a number of other events. She has an experience of working in small, medium and large medical centres, and has a very strong interest in leadership development, coaching, quality improvement, governance, business planning and financial management. She also is an experienced board member and is a founder of a very highly active and influential Facebook group, which is a bit of a mouthful, really, which is the Practice Managers Network, which has a global membership, as you can see on the slide there, of over 10,000 participants. So we really are pleased to work with Rivka tonight, and I would like to pass over to Rivka to commence the session.
Thank you so much, Jeanette. It really is lovely to be with you this evening to talk about that meaty subject of triage in primary care. It's an important topic, and we don't see that much training happening anymore at this point in time. And so we thought a bit of a refresher to particularly focus on the role of non-clinical staff, so reception staff, certainly practice managers as well, in terms of getting triage happening there. Now, before we really do kick off, I would also like to acknowledge the traditional custodians of the lands on which we are meeting tonight. I'm paying my respects to elders past, present and emerging, and a very hearty welcome from Judgerung country. I'm located in Central Victoria. So let's kick the session off, firstly, by inviting you to please ask your questions, anything related to triage. We're going to be more than happy to cover off anything that's worrying you or that you are not feeling too certain about. So please feel free to pop your questions into the box. It is anonymous, and we will bring them to life as the session goes on. Towards the end, there will also be an opportunity to ask some further questions as well. There is a fair bit of content that we need to cover off on tonight, so you'll probably hear me speaking sort of, reasonably fast. So do ask for a slowdown and further explanation if you feel that that's going to help you. So let's get started with basically a bit of a definition of what triage is about. And so triage, that word, it's a French word, and it really came about, in wartime situations where casualties, the soldiers, the personnel who were injured on the front line needed to be prioritized in order of urgency, in order to get, to get their service happening in a sequential manner. The most important, the most urgent are attended to first, and those of lower priority or acuity may need to wait a little bit longer. So that French word of triage, it literally means to sift. So that's the French word for sifting. And there's a bit of a Google definition there of triage on the screen for you there as well. So there are lots of components as far as triage is concerned that will determine the effectiveness of your overall system. So one of the key messages for tonight is that triage is not a one-person event or activity or an exposure for, reception staff or practice managers alone. Effective triage is really that all-encompassing system, policies, procedures that you have going within your practice, that when you do all of those components well, what you end up is with a much safer and more effective triage system within your practice. So if we break that down, it really consists of, first and foremost, orientation and training, making sure that new staff who come into your practice are provided with that opportunity to learn about what their role is in triage. And this is especially, of course, true for non-clinical staff as well, who may not have encountered this particular activity that is common in primary care at all. So it's really important that that conversation takes place right at the outset. Staff also need to undertake regular CPR training, and I'll say a little bit more about that as well. It is also, of course, related to your accreditation requirements. Some of the ways in which we can really sort of embed good triage processes within our practice is to introduce some mock scenarios and role plays to kind of have a bit of a test drive and a dry run for how would we manage when we are full up and we've got no capacity and something more urgent comes along. So role playing that amongst your clinicians, amongst your reception staff, and having some acting as, as I guess, dummy patients is a really good way to test your systems and find the bits that aren't working so well so that you can address them going forward as well. A really great way too to keep track of where is everyone at in terms of their understanding, and this is certainly not limited only to triage, is to undertake some regular skills assessment and, keeping that in a matrix form. Spreadsheets are really, really great for that, and keeping that updated so that as a practice, you are familiar with, where your staff training is at and perhaps where some of those gaps are. So that's kind of some of that scaffolding that you will want to have in place to support effective triage when all is said and done, and you've got, a patient in front of you that needs scrutiny in terms of their urgency. Also really important, of course, are the clinic processes and protocols. You do need policies, guidelines, procedures in written format. They need to be documented and they need to be understood by your practice staff. That outlines how do we do things around here as far as triage is concerned. And this is where the Pop Guns Guide really comes in. I'm going to say more about that. If you're not familiar with that terminology, don't worry. I'll cover that off in some later slides there. And really, you need easy access to all of those resources so that when the heat is on and you find yourself in a tricky situation, that you've got some really good resources that you can lean on to help you make those decisions quickly, effectively, and most importantly, safely. You also need supportive resources. So this kind of comes down to staffing and rostering. Who have you got in your team? Who's working at any given time? What's that clinical expertise that's available at any given time that your practice is open, that you can rely on to support these triage decisions and, be able to escalate to? So again, this is certainly not a receptionist only, process or activity. You need to have a team around you to be able to help out in that way. And then overlaying all of that, and perhaps one of the most important components, is effective communication within your practice. So that really overlays that whole notion of orientation and training and policies and protocols and meetings. And do we feel safe in our environment to ask questions and to really sort of, dissect the processes that we've got in place? So that can't be underestimated, that the better your communication systems within your practice, the more easily you can put in place effective processes for triage. So let's have a quick look at the accreditation framework and what is expected of us, because that kind of sets the scene for what you need to have in place in your practice. And for the medical receptionists who are in the room tonight, this might prompt you to ask some questions of your practice. If you think some of these elements are maybe a little bit underdone, or you need some additional support in that, you can kind of bring that to your managers and to your practice owners and say, hey, I think we can possibly do a little bit better here. So these are the expectations of the RECGP accreditation 5th edition standards as they stand at the moment. So GP 1.1b, and that's just simply the nomenclature that is used for identifying different standards, criteria, and indicators. So this B is an indicator. It states that our practice has a triage system. So triage systems, it's basically a statement that you must have that in place. So it's an expectation that these protocols are actually well developed within your practice. And what that means is that you've got to be able to demonstrate that prioritization of patients according to urgency and need, and you've got to have some evidence of that. So some of that evidence and the ways in which you could show some compliance there is to have triage guidelines at reception, and evidence that this is easily accessible and in use. So the surveyors will certainly be asking your practice staff to say, what triage guidelines do you use when when you have some patient prioritization questions that you need to deal with. This is where that pop guns guide is going to come in, and again I'm going to talk about that in a moment. Triage flowchart, that really is what that pop guns guide is all about as well. You need to have display signs in the waiting area to advise patients, to let you know when something isn't right, when they feel that their urgency is higher than perhaps what's been previously considered, to come and see you and to escalate that. So patient communication is really important there. And that kind of comes to that last point on the slide here. The base requirements, therefore, then, are that all members of the practice team must know how the practice, and of course by the practice it means the staff within the practice, identify patients with an urgent medical need. That needs to be established. Identify the medical emergencies and the ability to reprioritize appointments in accordance with that urgency. The ability to seek urgent medical assistance from the clinical team, so very important that you're able to escalate that up to your nurses and to your doctors within your practice. And dealing with patients who have urgent medical needs when the practice is operating at capacity. And this is a really important factor because, of course, if you've got capacity within your practice at any given time and something urgent comes up, then fitting that in and getting that attended to is reasonably straightforward because you've got that capacity. But it's when you're full, your books are full, you've got no spare appointments, and something crops up that looks like it fits into that more urgent space, that's when this whole process really kicks in. So that's an important hallmark for you there as well. GP 1.1c, again, another indicator, states that our recorded message advises patients to call 000 in case of emergency. So that's even, before they come into your practice. What I want to flag here is that that was not mandatory up until February 2023. So some new updated standards have come in, and now this has become mandatory. So if you get gearing up, getting ready for accreditation, make sure that you do have that in place. There is a 12-month period, so 12 months from February 2023, so that's next year in February, that absolutely must be in place. And if you don't, that will be counted as a non-compliance for the practice. So that's important to know. So you've got to do that when patients are on hold. If your patients can ring the practice and you put them on hold, there must be the capacity to have a message on there that requires patients, or it instructs patients in accordance with that scribe of, call 000 if you're experiencing an emergency. And there are a couple of other suggestions there too. Staff training on how to respond to emergencies. Guess what? That's what this is tonight. Triage guidelines at reception and a triage flowchart. Indicator C8.1A states that our non-clinical staff complete training appropriate to their role and our patient population. So that's a requirement that needs to be done on a continuous basis. And then indicator B states that non-clinical staff, so again, reception admin staff, must complete CPR training at least every 3 years. So that's an important one that relates to triage as well. GP 3.1 states that all members of our clinical team have undertaken training in CPR, so cardiopulmonary resuscitation, in accordance with recommendations of their professional organisation, or at least every 3 years. So that relates to your doctors and your nurses. And furthermore, there is an indicator that speaks to the management of cross-infection within the practice. And there is a particular point that relates to triage of patients with potential communicable diseases. So how do you manage your patients with respiratory symptoms? Of course, we've all become quite expert in that over the time of COVID of late, but you need to be able to demonstrate what those systems are and how they apply in your practice. There are a couple of additional new requirements that I do want to just quickly draw your attention to. GP 5.2, you now must have an ECG on site. Previously, that was a recommendation in terms of you need to have timely access to an ECG. Now you need to actually have that on site. You also must have a defibrillator on site, and you need to have signage within your practice as to where that defibrillator is located. And of course, along with the defibrillator comes training to ensure that your staff are able to use that equipment when required. Again, like I said before, these changes came in February this year. So there's about a 12-month grace period before this absolutely needs to be embedded. But if you can do that now, get on with it because it needs to be in place. There's a bit of a QR code there on the screen for you. You can zap that and get access to the updated standards. So there's a lot more than what I've just gone through here. I've just picked the ones that are relevant to triage, but there are some others. And the URL is just down in the small text box down the bottom there below. And the PHN is going to send you those direct links through some messaging tomorrow after tonight's event as well. So let's come back to that core notion of triage and what that is all about. So what does your reception staff need to know? How do you navigate your way around these triage questions? And I really like to sort of see it in these sort of 3 categories of we need demographic information of the person in front of us or the person on the phone. We need to know, who are you? Where are you? Can we contact you? So for that, we need name, and I'm sort of really saying you want your 3 approved identifiers kind of kicking in here as well. So you absolutely want to know what the patient's address is and their age. And this is very pertinent, of course, if the patient is on the telephone saying, I'm in a bit of strife here. You need a telephone number, confirm that you've got the correct number available so that you can get back in touch with the patient as well. And you need to know where they are. They may not be at home. So confirm that demographic information first up. Then we need to know what's actually going on. So what's the issue? What's the nature of the symptoms that are in front of you? And of course, that can be really broad and wide, and we're going to chunk that down a little bit in a moment as well. And then very importantly, that 3rd category is around context. And this is so crucially important when we're having these triage kind of conversations. We need to know what's going on with you, but also how long has this been going on? What's the severity? And is this possibly related to some previous problems? So there are some, I guess, some further explanatory questions to get further context of what are we actually dealing with, because it's going to help you decide, is this more urgent or are we not too bad in this space? So let's give you an example here, right? Bit of the devil in the detail. If your reception staff or you as a receptionist pass on information to your nurse, I've got someone on the phone with a bleeding finger. That's really limited information. And on the basis of that, we actually don't really know what's going on. So compare that then to having that further context around that situation. You've got a name, Damien Smith, and it's his partner on the phone. He severed his finger with a chainsaw 10 minutes ago. That sounds pretty serious. It's bleeding right through the towel. He's 25 years old. You can already see that that kind of gives you a much broader picture of what's going on here. And this sounds urgent, right? It needs to be escalated up. Versus the same person, maybe on the phone, his finger is still bleeding from a knife cut a few hours ago, and he's thinking, do I need some stitches around that? So that's a very different conversation that you're having there, and this is why having that context is crucially important. So let's then come to that PopGuns guide. And the PopGuns, it's an acronym. It stands for Prioritisation of Patients. It's quite a mouthful here. Prioritisation of Patients, a guide to urgency for non-clinical staff. So this is kind of the Bible that your reception admin team use to make decisions about escalation and seeking further guidance from your clinical team. And it's basically broken down into 6 sections of urgency. 1 is an emergency, call 000, get immediate help. Number 2, in the box there, the orange, go to emergency, interrupt the GP or a nurse. 3, the yellow one, advise the GP or the nurse kind of now. Attend the clinic is number 4, discuss it with the GP, come today, let the nurse and the GP know. And then number 6 is essentially non-urgent, attend within a day if possible, and with that caveat of call us back if things get worse, right? Because things don't always stay the same. We need to advise patients to let us know when their circumstance changes. What I kind of want to draw your attention to here in terms of these 6 categories is you can see that's really pretty fluid, isn't it? So I would say that perhaps the difference between category 2 and 3, go to emergency or interrupt your GP nurse, versus advise the GP nurse now, that's kind of very similar, isn't it? So I want you to kind of get comfortable with that ambiguity around where does a position sit, where does an issue sit within this guideline. Now, what I love, and hopefully you'll have this guide within your practice as well, is if you can make some space on these guides and have copies of that available where reception staff can quickly take down name, address, telephone number, ask the patient what's going on, circle where it sits within the PopGuns guide. So you can't really see it on the text here, but we'll talk through the detail to say, okay, your issue sits within category 3. What's the context? Does it need to get shifted up in urgency, or is it actually okay? So some of that decision making can happen quite quickly and easily, and you end up with some really great documentation that you can then scan into the patient's file, and guess what? You've got your evidence of triage decisions and how that's been enacted within your practice. So that might be something for you to consider if that's not what you're doing at this point in time. So what happens when, it looks like we've got a category 1 presentation and calling an ambulance? If we've got the patient on the telephone, we kind of need to ask ourselves, can this be safely undertaken by the patient or the carer if the patient is describing some of these emergency kind of symptoms that really require that immediate referral to an ambulance? So are they actually capable of doing that? What's going to be the fastest and most effective way that that can happen? So sometimes it might be that the practice actually steps into that space to actually facilitate that ambulance calling on behalf of the patient. And you'd want the person who's clinically most senior in your practice to do that. So the receptionist would be handing this through to a practice nurse or a doctor to provide assistance there. So this is not a solitary activity that a receptionist would undertake. But we do need to know the location of the patient. So if the receptionist can gather that information right at the outset, that is extremely helpful. Is the patient home? Are your details up to date? Do we know where you are? The telephone number, as I said before. Access instructions, making sure that doors are unlocked and ambulance staff are able to gain access to a patient who may be deteriorating, and keeping the telephone free. So making sure that the patient or the carer is not going to be making phone calls outside of that if they are expecting ambulance to get back in touch with them as well. So those are some of the important considerations there. So in terms of category 1, those most urgent presentations where we are expecting O to be called and the GP and nurse to be involved with these decisions and conversations immediately, are things like chest pain, difficulties with breathing, and that can certainly include allergies and asthma. They can be quite dire situations, so be aware of that. Any kind of collapse or altered consciousness, so feeling like there is that loss of consciousness, or feeling really very faint as well. Facial or limb weakness, and we'll talk a little bit more about that in a moment as well. Extensive burns, so a significant burn if that has been experienced. And again, really loose here, right? A sick patient with concerns. This is the wording out of the Popgun's guide. If the patient says, I'm very concerned about how I am feeling, you need to pay attention to that. So please don't dismiss that. So some of the heart-related symptoms that you will want to be aware of is pain or heaviness or tightness. And one of the S's has fallen onto the next line. Tightness in chest, jaw, arms, neck, back, teeth in the jaw there, upper abdomen. So any kind of sensation and discomfort in that area can be indicative of a heart-related symptom and is absolutely cause for concern. Shortness of breath, dizziness or fainting is really important. Heart-related symptoms can also include nausea and vomiting, often in association with some of that sort of chest tightness and just not feeling right. Anxiety and sweating. So you can kind of really build up that picture of a patient who's feeling very uncomfortable with any or all of those symptoms. Your antenna needs to go up and go, oh gosh, could this be important? What I also want to stress as far as the heart-related symptoms is that often what we find, especially with female patients having a cardiac or a heart event, these symptoms can be really quite subtle. And that's tricky, right? Because it may not arouse our curiosity or our urgency awareness. So be aware that sometimes these symptoms are not, the sort of classic signs that you see on TV shows where, the clutching of the chest and, falling on the ground, and sort of that really dramatic presentation can be much more subtle than that. So be on the lookout. So in terms of the management of that chest pain, if the patient is on the phone, you call an ambulance immediately or get their carer or assisting person to do that. That is the right advice to give there. If they are actually at the clinic, then your first protocol would be to gain the assistance of your GP and or nurse. You then may well become part of the support team in terms of calling for an ambulance if you are instructed to do that, especially if there is no nurse available. You might be quite involved in some of these activities. You can certainly help to make the patient comfortable sitting down or lying down on the ground as well. And there is no problem with laying a patient down in the waiting room if that is the most appropriate, action to take. So don't worry about how it looks or how it feels. Make the patient comfortable. That's very helpful. Stay until help arrives. So don't do a runner. That wouldn't be a good idea. And if required, commence CPR, apply defibrillator, and follow instructions. And that would specifically apply, of course, if a non-clinical staff member finds themselves without a GP or a nurse to help out. This is why we need to have CPR training, and this is why we need to be trained in using a defibrillator as well. Hopefully you don't find yourself in these situations, but you know what, these scenarios, they can also happen outside of the practice space as well. And if you're able to provide assistance, then that would be really terrific. In terms of stroke symptoms, the acronym that goes along with stroke is FAST. F-A-S-T, and it stands for face, arms, speech, and time. So in terms of face, what we can see often with stroke patients is, half their face is drooping. So they may have, quite an odd looking face, and it's kind of looking a bit peculiar. Of course, along with that, they may well have some speech problems to go along with that. They also may have limb weakness, and it can frequently be just, one side. So one arm is not quite working right. And they may have that sort of slurred speech, or not being able to sort of articulate very clearly what's going on. And then what that means is if you have any of those symptoms, either alone or together, that time is of the essence. So 000, you need to get on with that and get assistance quickly. In terms of category 2, so we're now starting to step through that sequencing of urgency. Immediate care, still important, right? If they're on the phone, advise them to go to emergency. So the kinds of scenarios that would fit into that is patients who are fitting, experiencing heavy bleeding, trauma, spinal or head injuries, and I'll have a bit more to say about that in a moment. Snake bite, heart palpitations, perhaps without some of those other symptoms that I was describing just before. A pregnant female going into labour or having ruptured membranes, neck stiffness or altered consciousness. So again, you can see even in this category, context is everything, right? Because, trauma, well, a head injury might just be a very mild bop on the head, or it could be something really significant. You really do need to know the context around what is going on there. If the patient is at the practice, again, you would get the immediate assistance of your GP and nurse and get them involved. Redirection to the emergency department, because that is where that care needs to take place, and call an ambulance as directed. And depending on your practice, you may be involved in stabilisation of those patients, or it may be, a direct redirect to emergency departments there. Category 3, again, stepping down in that acuity there, where you are expected to interrupt the GP or nurse. So this would be an immediate advice to the GP nurse if a patient can't go to the toilet, they can't urinate. If there is a sick child, and so that's quite a loose statement there as well, but any infants who are unwell, so we're talking about babies, that needs to have some pretty immediate attention. Poison or overdose, eye injury, severe pain, and fractures. So we're kind of coming into the grey zone here now. And so that notion of interrupting the GP nurse, it might be pick up the phone and say, look, there is a patient here. What do we do with this? Can I hand that over? Or what other questions do I need to ask? And that notion of psychological safety for your staff to actually go knocking on the door of the GP or the nurse at any time and say, I'm concerned, help me out here. What should we do? So how do those conversations take place? And is it okay for those questions to be asked? And then finding that the urgency is really not there, but it was a perfectly valid question to ask. So I'd really sort of challenge you to think about how your practice kind of intersects with, with that kind of presentation, and how that communication really takes place within your practice. Category 4, come to the clinic now. So that would be unwell children or the elderly with fever that's been there for more than 24 hours. any pain or bleeding in pregnancy, visual disturbance, abuse or assault, and they can be really quite tricky situations too, of course, for practices to deal with, a patient carer with high concern, and psychological distress. I can see Jeanette, you've popped onto the screen. I'm suspecting there might be a question in that for me.
Yes, hi, thanks. We've had some questions in regards to mental health issues, and I'm wondering if this may be the appropriate time or perhaps a little bit later, but how to triage people that may have a mental health crisis or have some mental health issues. So
yeah, look, I think, again, it's going to depend a little bit, isn't it, on the context of the practice, of what are the resources that you've got available to deal with this. Some practices are far more capable of catching, particularly mental health presentations and work, quite intensively with that. And other practices, perhaps not so much. So first and foremost, we need to understand the practice context and the capability there. Hopefully no patients in psychological distress get turned away. This is obviously an important presentation, and of course it can present as sort of quite aggressive behavior or peculiar behavior, certainly behaviors that make practice staff feel unsafe or concerned. So it can be sort of quite florid in its presentation, and of course it doesn't always need to be that way. But if there is a presentation of a mental health related type of situation, then I would say come to the clinic now. We need to do an assessment, and that is certainly not a role for a receptionist. But the patient needs to feel welcome to come in so that we can catch them and then, treat them, refer them, pathway them in accordance with, well, what's going on with the patient and where do they need to go. I guess it's also a little bit of a broader conversation too, in terms of how these patients present in terms of staff safety as well. So that's probably a conversation for another time, in terms of dealing with challenging behaviours and how you kind of navigate your way through that. That's important to consider as well. But I think, by and large, if disruptive behaviour kind of comes your way, perhaps the default needs to be of what's going on for this patient, what's going on beyond, perhaps aggression or bad language or challenging behaviour, where we're recognising that a patient is actually in dire need of support and help. So that would probably be the best guidance that I can give. But, there are a million different presentations and situations. So it's really difficult to answer that with sort of any definitive process. I think for practices, they might ask, who are some of the patients that we are concerned about, that they may have some of these issues? They could well be frequent flyers. So identifying them and developing a strategy within the practice of how do we best support these patients. Or, mock scenario, role play this of how do we actually deal with patients who come in with mental health crises, whether it is psychosis or, or another mental health type of presentation. How do we react? How do we support? Who do we call in? How do we best support those patients? And again, it's going to be different for different clinics, different contexts. I hope that's answered the question sufficiently, Jeanette.
Thanks. Thank you. That's great.
Were there any other questions in relation to that?
Not at the moment, no.
Okay, wonderful. Great. We will kick on. Category 5. And again, we're really starting to step down in terms of that acuity. Attend soon. So soon, what does that mean? If you've got capability, it could come right down. If you're a bit busier, then you're going to have to sort of allocate, the right resources and do that prioritisation, that shuffling of patients around to ensure that these patients do get attended to. So this relates to unwell children, the elderly with fever, vomiting, diarrhea or pain less than 24 hours. So more sort of an acute presentation than what I was describing with the earlier category. Rashes, cuts, lacerations, severe flu symptoms. So again, you can see cut, laceration, rash, even severe flu symptoms It may not be low acuity or lower acuity. Depending on the context, these might actually end up being really significant and need escalating up to a far more sort of florid response than just, okay, well, look, come on in when you're ready. So just take the words around the pop gun with a little bit of looseness, and don't sort of, hang your decision making on just those words. Remember your context and apply that sort of really cleanly to it, and ensure that you land your urgency in the right box, not just, saying it's a rash and therefore not terribly urgent. It needs to be attended to. It could be something, far more serious than that. And of course, I've already provided the example of the cut and laceration, where one is actually not urgent at all, versus, something that is actually, trauma, rather than perhaps a cut laceration. That's the presentation. And so we need to deal with that, quite differently. Just a little bit of a word on infectious patients. So think about your setup within your practice as far as isolating patients and what that scribe looks like. Again, I think most of you will be really well versed with that now. Coming out of, we're still in the middle of it, but, our COVID times have really beefed up practices' capacity to triage very effectively around COVID presentations, other respiratory viruses, and kind of deal with that quite differently to what we used to perhaps, before COVID times. So think about the protection of other patients and staff. So how do you bring patients into your practice? Do you bring them into your practice? Do you have separate treatment areas where potentially infectious patients get attended to? How do you communicate that with patients? What's the signage? What is it that you say to patients on the telephone when they indicate that they may have some of these respiratory systems? And of course, that relates very much to your pandemic plan and your COVID response and management system altogether. So very much part of that whole conversation around triage. So then coming into the sort of last category, where the recommendation is that an appointment within the day, within 24 hours, is really recommended and required. An adult with fever, but otherwise not feeling too bad. And remember, these things can kind of escalate. So that might be the presentation right now, but it may be different in 4 hours' time. So be aware of that escalation propensity and be ready to shift your approach to it in accordance with those escalation scenarios. Post-op problems, I've got a bit of an issue with categorizing that in number 6. I'm thinking some post-op issues could be, could be lethal, could be life-threatening. So again, context is absolutely important there. Eye or ear infections or eye or ear pain are, again, categories that can't wait for next week or the week after. Adults with continuous vomiting with or without diarrhea for more than 24 hours. And this is sort of, the beauty, all-encompassing phrase that contact us if symptoms get worse. And that's kind of what I was referring to in terms of that escalation as well. So some of the other considerations that, you want to have kind of, top of mind, be very aware of, is the patient who has a high level of concern. And remember, we spoke about that in terms of, even necessarily a category 1 presentation, that if the patient has concerns, you need to listen to that. You really need to get the detail of what are those concerns around, and certainly not be dismissive. And the other one is really the patient expectation. And there can be a real mismatch, can't there be, of, what the patient expects as what is called urgent versus what the practice might deem to be urgent. So some of that patient expectation might sit around a very busy schedule, and they feel they do need to be seen urgently. but not because of a clinical scenario, but essentially an administrative one. You know, it would fit their life much better to be seen more quickly. And this is kind of where that trickiness comes in as well, of course, in making sure that we apply that questioning around the triage to ascertain what is that urgency all about? What are the symptoms? What is the context around what the patient is experiencing, so that the practice can determine where that sits as far as triage is concerned, and then having to communicate with the patient if you do feel that there is that mismatch between their perceived level of urgency and the practice assessment of that as well. So in amongst all of this, as I said much earlier this evening, is that communication is really key to nutting this out and getting it right. So from the administrative side, what you want to ensure is that you've got your ears in listening mode. And this is notoriously difficult to do, especially with the busyness of your practices. You do need to kind of pause and be focused and aware and present in the conversation that is ahead of you and that you are in the middle of now. Listen for what's being said, and certainly in terms of tone and urgency that is being conveyed. Ensure that you've got the accuracy of the information that is being imparted to you, and then reflect on, what does that actually mean? Should I be concerned about this? And lastly, I want to just also bring to your attention an awareness of unrecognized urgency. And I'm speaking directly from experience in this, where patients are dismissive of their symptoms and they are downplaying how they're feeling or what they think the urgency might be. So it's kind of the flip side of what I was talking about just before in terms of, you know, patients with high expectations. This is the converse of that, where patients are saying, look, you know, my chest is hurting, but I'll be okay. I'll be okay. Can I make an appointment for next week? So that recognition that, oh, hang on a second, this is something that needs additional attention can be really important too. Now, reception staff may not always be in the position of picking up some of that unrecognized urgency, because if the patient doesn't disclose it, you can't smell it, right? You won't know that this is what's going on unless the patient actually proffers that information. And that's where your listening really comes in too, to listen for what's not being said. I know Mr. Jones, and he's not sounding himself. I'm worried about him. What's going on here? Do we have some of that unrecognized urgency that could be at play here? And, you know, certainly I've got the experience that a very aware receptionist intervened and in fact resulted in the patient getting treatment and their life being saved as a result of going, oh, hang on, I'm not okay with that. So, encourage your staff, and as receptionists, don't be frightened of overcalling a scenario that's in front of you. If you get it wrong, that's perfectly okay. It's better that you do that than not. However, if something happens and you were not aware of the situation that was kind of going on behind the scenes because it wasn't disclosed, then, you know, you can't beat yourself up about that as well. So, oh, hello, Jeanette. I'm just going to pause before I flip into the next slide.
Sorry about that. Yeah, we've had a question about a situation where the receptionist or the medical administrator might recognise something, something like a breathing problem, and are wanting to suggest to the patient that they go to an emergency department or have an ambulance called, and they refuse, and they're wondering how do we deal with those sort of situations? And I guess where is also the liability lying with that?
Yeah, look, I think, you know, the liability lies in the advice that we give our patients, and documentation. So you want to make sure that if a patient is refusing to accept your advice, that is documented, because you may need to rely on that, should things kind of go wrong. I think, again, it's going to depend on the practice's capacity to then support a patient coming into the practice. Sometimes patients feel safer if a doctor has eyeballed them and gone, no, you really do need to go to an emergency department, and then accept that advice. I'd probably sort of be cautious to sort of say, if you don't go to emergency, we can't help you. I think that that's very black and white. And I probably wouldn't feel comfortable with my practice being so sort of definitive about what you will or won't do. So again, think about the patient context. Where are they at? What are the experiences that the patient has that has resulted in them saying, I'm not going to an emergency department? Could it be that they feel culturally unsafe in that space? Are there other experiences that kind of fit into that? So I think we need to recognize the nuance in some of these situations rather than seeing them as really black and white, and work with that nuance and the shades of gray, and come from the perspective of saying, what can we do? This is our best advice. If you won't take that, don't put the barriers up, and say, what can we do next to help you best in this scenario? So I guess, that would be my approach. Maybe, not everybody would agree with that, but I think we really do need to be comfortable with nuance and not be too black and white thinking in any aspect of really healthcare, because it is really complex, isn't it?
Indeed. Thank you very much.
Terrific. Okay. So, some of the communication challenges that we deal with as well that can make these triage decisions and communication a little bit difficult, a little bit fraught, could be language barriers, cultural experiences, and I kind of just hinted at that just before too in my response to Jeanette. A patient's ability to actually understand what's being asked of them. Time pressure, and this is particularly relevant to busy reception staff when your phones are ringing and doctors are demanding your attention and patients are in front of you. The ability to think clearly about what's going on in front of me and what I'm dealing with can absolutely be compromised. And this is kind of where resourcing comes into it as well, to say, is what we're doing, safe? Is it okay? Can I think effectively given the environment that we are in? It speaks of distraction, doesn't it? When we've got 10 things happening around us, much easier to miss important cues and important information. So what are the strategies that you can employ within your practice? And I'm hoping that some of these dot points kind of prompt you to think about, how does that apply in our practice? What do we need to think about? What do we need to flesh out in order to play in this space as safely and effectively as we possibly can? And I'm really keen to kind of hear your questions and comments and feedback around what that looks like within your practice too, if you're happy to share. So some of the key messages, we're sort of, coming into the last moments of the webinar. Some key messages: understand the triage process and apply it consistently. So avoidance of staff making individual decisions about how they go about this because they feel that they have the system worked out. We need to all be singing from the same songbook, so that consistency of approach is really, really important. No one should go rogue on these triage decisions and, even veering off into providing clinical advice to patients. But, I feel like I know what needs to happen here. As a non-clinical person, you really need to sort of stay away from that. The currency of your CPR training, of course, this is all part and parcel of accreditation as well. But if you haven't undertaken that for a while, really good idea to keep that fresh and up to date. And of course, in red, context is everything. You cannot make these triage decisions without asking those context questions: the duration, the severity, what else is going on for this patient, to paint that full picture. Working within your scope of skill, experience, and practice. So don't step outside of those swimming lanes. When you're feeling uncomfortable, get help, get advice, lean on your clinical staff, because they are the experts, of course, in that clinical management. Know how to escalate quickly. Which door do you knock on? which doctor is present today? Where is the nurse located? Can I interrupt at any time? Is that a knock on the door? Is it a phone call? Is it a public announcement? How does that work within your practice? And all of those are okay, but how does it work within your practice? How do we raise alarms? Can you use your duress alarm buttons if something's happening right in front of you, where you can kind of call on the entire team to say, come and help me out here? What does that look like within your practice? And of course, effective team communication. Like I said, really delving into that is probably the topic for another webinar down the track, but it really is at the heart of making these workflows effective and safe, and hopefully with positive outcomes for patient experiences. Okay, so here are a few resources for you. Make sure that from the practice perspective, you've got your contacts ready access. So ambulance 000, you want to make sure Health Direct is on your list as well. Nurse on call, know your local hospitals and your ED services. Go and shake their hands if you're not that familiar with them. Introduce yourselves to them and build those relationships so that that escalation can also happen nice and quickly. What are the after hours services that are available in your location as well? So understand that command structure for your practice. And of course, have the pop guns, the prioritization of patients, a guide to urgency for non-clinical staff. Have that available at your front desk where your receptionists are working. The Northwest Melbourne PHN will issue, their version of the pop guns. It's pretty consistent around the country. Your own PHN, if you are from outside that catchment, will also have versions of this resource. So make sure that you're really familiar with that and that you use it as well. And so I'm going to pause it there now and see what other questions have popped up during the time that I've been on my little journey here. So Jeanette, I'm going to just invite you to let me know if there are any other questions that the team would like to address. And of course, there's plenty of time for you to get your questions in and for me to answer those as well.
Yep. We have got a few comments and questions.
Okay, excellent. Do you want to pop your camera on so I can see you?
Yeah, apologies.
There
we go. Thank you.
That's excellent.
Not a problem. And they relate to, I guess, patients that are coming in that might not really be appropriate for the clinic. So a couple of things was about patients all feeling they're actually urgent. And so how do people successfully manage that feedback if the patient isn't urgent, they have to wait, or perhaps in some settings they might not be appropriate for the actual clinic to attend, and so what's the best way of providing that back?
Again, this really comes down to communication, doesn't it, in terms of patient expectation and also what else is happening within the practice. So it may well be an explainer to the patient who does need to be attended, but we can't do that right now because there's other urgency that we are dealing with. That's the triage process, right? It's the reorganization of patients according to the urgency that's right in front of you at this time. So the openness of communication with patients is absolutely key. Keep them on board, keep them informed, and keep them up to date with why something needs to happen in a certain sequence. So you need to be sort of transparent about what's going on there. For a patient who rocks up and says, well, I am urgent because I deem it to be so, you need to, of course, really diplomatically have that conversation around your capacity. The books are full. We can't accommodate you right now in accordance with our clinical guidelines. The urgency indicates that we need to attend to you within, X amount of time. Again, probably by the time it gets to that point, it's more likely to be a conversation that's being had with a nurse or even with a doctor. But you've got to paint the picture for the patient. They really don't know. So openness of communication is really, really difficult. I think, once you start to sort of get into that space of argy-bargy and displeasure and, a bit of conflict as far as what should we do next, well, we then kind of fall into that space of, how do we deal with these difficult conversations? Could there be a mental health presentation that we are inadvertently dealing with? And do we need to sort of say, okay, we need to actually change our mind about what we do with this patient, and that's okay too? Or is this, unacceptable behavior? Does it sit more within that zero tolerance framework of you really do need to be respectful of what we're able to offer and not offer, and here are the options available for you there. So again, it kind of fits much more into that space of, highly developed communication skills, de-escalation, and just sort of managing patient expectations more generally. I hope that's kind of covered that off reasonably.
Thank you. We've got another couple of questions which really relate to the team, I guess, and for clinics that get in trouble, perhaps when they've accepted patients that they shouldn't have. That was one of the comments, that sometimes there are grey decisions that are made, and there is some concerns that as part of the team, they've made the wrong decision and how to manage that. And there's another question kind of on the same theme, which talks about a duty doctor system to help with triaging. And this, I'll just read this, is probably easier. Yeah. So as the PM, how would you deal with GPs who are perhaps less helpful or responsive? And this is in terms of having a duty doctor system. And it's creating hesitancy in the reception team and could potentially cause delay in an urgent situation. So look, it's that team stuff that's come through.
Oh, absolutely. And you'll recall the earlier slide that I had up in terms of the psychological safety for the team to actually lean on the clinicians. So it kind of speaks a little bit about the practice culture, doesn't it? Where staff are kind of going, don't want to interrupt the doctor or the nurse, whatever that might look like, because I'm frightened of how that's going to land and, what the outcome is going to be. And I think, as a practice manager, it's really opening up the communication around the effect of those approaches and how that lands with staff, and then the risks that result out of that. We need to open up those conversations. It may be that a clinician or doctor may be quite unaware that the way that they manage this or respond to it is actually landing a bit flat. So first of all, is there awareness there? And, how ready are they to, to kind of go, oh, I see what you mean. And I possibly need to modify the way that that I allow that to happen. And I think, the idea of a duty doctor where someone is responsible for this for any given shift, it's a great idea. If that works within your team, that's awesome. For some practices, that might not work because there's just not the resourcing to be able to, have different people allocated, to that role. So again, it's just so dependent on the context of the practice. But I would say it's, quite a red flag that if staff are feeling unsafe to knock on the door and say, can you give us a hand here, or tell me more about what I should do next? They should feel safe to do that. The flip side of that is if the questions or the scenarios are being deemed to just not be appropriate, then is there a training problem? Has the staff member received sufficient orientation and training to actually understand how they most effectively play in this space? So it could be any number of those factors. And again, it's really impossible to say this is the answer to all of those scenarios. You really have to dig into what's going on within our practice that's making this, really quite difficult. I know, in terms of the scheduling and how do we deal with urgency on the day, for larger practices, it's quite common to have a treatment room doctor where they don't sort of see a normal patient cohort, but they see all of that overflow. And that, of course, for reception staff, admin staff, is wonderful, because that notion of having to apply the triage framework is lowered because you've got capacity. right? When you've got the capacity, it makes all of this super simple. It's really when your books are full and, you don't have the capacity, that's when triage really kicks in, and you need to think about, where do you fit in? Do we need to bump someone else down the track in order to fit in this urgency? And then, of course, the patient who gets bumped needs to be very effectively communicated with as well.
I think that's a really valid point of that process of triage, isn't it? Because people's expectations are a bit kind of concerned if someone jumps in front of them, but
exactly.
being
and
explicit.
It's not easy. I think, to sort of think that there is a magic solution for every situation, that's just not the case, right? I mean, we're dealing with people and unpredictable behaviors and approaches. So it's tricky. That's why we need to continue to immerse in the themes of what can we do to best prepare ourselves for these situations and sort of avoid some of those pitfalls as best we can. It probably isn't going to get to the point where it is totally eliminated. I just don't think anyone would be in the space where they can say, oh, this is never an issue for us. I just, that doesn't ring true either, does it?
No. Rivka, there was another question that came through and asking you to talk about the importance of on-the-day appointments and how triage plays a role in this and how these are booked rather than just who gets in first. So it's... question.
It's a beautiful question. It's a fantastic one. Look, the notion of, on the day appointments, most practices do have some capacity for patients, to call in at the start of a day and not have the books totally full. So that's a good thing to do, because we do know that urgency does arrive on the day. And if we prepare for it, it's easier to deal with. So that's one thing. But of course, the problem with the on-the-day appointments is that surreptitiously we are training our patients to bypass a triage system and simply ring early in the morning to gather some of these sort of urgent appointments on the day. And so then it kind of, completely invalidates the purpose of having those appointments, and patients get sort of really clever at being able to bypass the situation. So again, the on-the-day appointments, they do need to have an element of triage applied to them to really understand, what is this all about? I think, it's a bit of a heart sink for many receptionists to open up the phones at 8 or 8:30 in the morning and get hammered with the patients who know you've got appointment availability, because they understand what your system and process is, and then put pressure on reception staff to simply, be allowed to take those appointments. So, look, I guess, a strategy that we used to use in the practice that I worked in is that these sort of situations actually became really quite tricky. And so we also introduced the notion of a patient deemed urgent appointment. So we're not talking about the sort of the high acuity in terms of the pop guns that we've been talking about, the category 1, 2, 3s. We're talking about, patients that are really, really, really need to come in. And I think it's urgent. So rather than getting into a bargaining situation and not being able to satisfy the patient, we allowed receptionists to classify these appointments when they were taken as patient deemed urgent, when there wasn't real clarity around the actual clinical need. And so the system then was that the GP who would see that patient would see that that appointment was booked as a patient deemed urgent, and it was their responsibility that if they felt that the presenting complaint really didn't fit the categorization well, that they would actually bring that up with the patient and say, look, what's actually happened here is you've taken an appointment for someone who really can't wait on the day. would really appreciate it if you keep that in mind when you use our appointment system. And I've got to say that was a successful way to go, because the patients really got the message that there is real need that sits behind these sorts of appointments. But you can see, there's a fair bit of sort of management and sequence and process involved in managing that. And look, it's tricky. Patients know how to bypass it. But look, what we do know is that there is predicted urgency that does fit into our schedules. So, do allow for it, and ensure that also doctors have access to more urgent appointments for patients who they are concerned about, so that they can say, I really want to see this patient tomorrow, and not find that they don't have any appointments for the next 3 weeks, because that's very difficult for clinicians to work with as well.
Thank you very much.
Okay, anything else? No more. Okay, well then I think we are just about at the end of the session here. I want to just point you to the feedback, and I'm sure you will get a follow-up email as well with the evaluation. We're very grateful if you could just take a moment to complete the evaluation. There are some further sessions. Jeanette, did you want to speak to that?
Yeah, that'd be terrific. So particularly for people that are working in priority primary care centres, we do have a session next week, and Rivka will be available again. So I really encourage you to, if you haven't booked into that, please come along. It isn't a replication on what we've talked about tonight. It's a little bit more in depth, and I'm really welcome to hear all of those comments and thoughts that you might have at that session next week. There's also obviously further education sessions available on all of our PHN websites. For us, that's the Northwest Melbourne one, but if you're coming from other areas within the state, please reach out to your folk out there, and they will also have other sessions. And finally, this session is recorded, and you'll be able to look at that link shortly and have another look through Rivka's wonderful presentation.
Terrific. Lovely to be with you all, and good night. Hope you have a lovely dinner, and I may see some of you next week as well. So thanks so much. I really appreciate your questions and your attendance.
Thank you.